30s, the treatment of vascular disease was limited to amputation, sometimes division of the tendo Achilles, and lumbar sympathectomy.
If we go back to 1956 or 57, the new hospital PA had opened, and the staff decided that vascular surgery should be promoted, whatever it meant. Well, in Australia, there was a very small group starting out in vascular surgery in the 1950s. I think Alan Sharp was a great originator. Didn't get much recognition, I don't think. John Lowenthal, also in Sydney, was marvellous supporter to us when we started.
When he came back to Australia, he was appointed to the staff at Prince Alfred as the visiting surgeon, or an honorary surgeon as they were called in those days. And the extent, though, of vascular surgery then was, and this is in the early 50s, would have been limited to sympathectomies and amputation. It was quite a step forward in 1956 when he did the first aortic aneurysm operation.
The first artery graft in Sydney was a homograft done by Alan Sharp at Sydney Hospital in 1956. Now, when I first got to know Sam, he was already doing hundreds, and I thought Sam was doing more arterial operations than anyone in the country. But it was all happening pretty quickly. By 1959, everyone was doing arterial operations.
At that time, a new appointment was made in terms of a full-time surgeon who was known as the surgical supervisor. I think Bob Shannon might have been the second of those surgical supervisors. He developed a particular interest in acute arterial disease because he had to face the abdominal aortic aneurysm patients. Very experienced, acute general surgeon, and a very capable one.
In the early days, vascular surgery in the North Island anyway was done by cardiothoracic surgeons, or cardiothoracic and vascular surgeons. And that followed on largely from Barrett Boyce's training at the Mayo Clinic in the United States, where vascular surgery was done in those units in the United States.
In those days, we all had to train in England and get the fellowship there because there wasn't a training program in Adelaide. A fellow called Cockett got the job, as you may remember, his operation on the perforated veins, and Savage got the job in Warwick. Fortunately for us, this chap really got stuck into vascular surgery. We were sort of learning how to do the anastomoses and making pretty much of a mess of it in most cases. I used to say to my friends that we do the bypass on Monday and I do the amputation on Thursday.
My most vivid memory is the earliest memory. We were 50 medical students rostered to casualty, and a patient was admitted with a leaking abdominal aortic aneurysm. Weary Dunlop was in the large crowd that was watching this procedure, very frustrated that he wasn't doing the procedure, and indeed about halfway through he could contain himself no longer, went outside, scrubbed up and joined in totally uninvited.
I think Mr. Doug Leslie and the late Sir Edward Dunlop took an artery from a cadaver and put it into the femoropopliteal situation. I did have the job of looking after the arterial bank at the hospital, so I had some interest in arteries, but it was an article from Houston on 317 femoropopliteal reconstructions and another on 4 repairs of thoracoabdominal aneurysms, 3 of whom survived, that astonished me, and I felt I had to find out a bit more about this. We could scarcely believe at that time that such operations could be done.
Well, Officer Brown was really the major contributor to the Alfred In the old days, he was a general surgeon to begin with, and then he specialised in thoracic and graduated from there to cardiac surgery. Alf Barnett referred him a patient with popliteal aneurysm, which he repaired. It must have been a very favourable sort of aneurysm because he simply cut it out and excised it as was the wont in those days, and rejoined the vessel by an end-to-end anastomosis without any interposition of anything.
I did my first vascular operation in 1949. Now you can't beat that, any of you fellas here. And I was the senior in casualty, and a woman came in who had a cut throat. And the usual procedure was to take them into the little operating theatre and examine it and see what happened to be done, whether they had to go to the theatre or not. And as we put her on the table and extended her head, a jet of blood hit the ceiling. And I was there with a young nurse, and I grabbed one end of it, and we set it up with, I think, 3 or 4 rows silk.
My first exposure to vascular surgery actually was as a child, because my father and uncle were intimately involved in the development of a cryosurgery at St Vincent's. My father was the chief engineer at Westinghouse and set up the frozen refrigeration for it, and Garvin was the pathologist, and my uncle Justin Fleming was the surgeon. It was an era in the 50s where there was a generation of post-war surgeons who were actually properly trained, rather than the GP surgeons who dominated the field, I think.
Instrumentation improved in the early 60s. You have soft atraumatic clamps, various shapes and sizes that you could really manoeuvre into tight situations.
One of the great changes that occurred there during the 60s was blood transfusion. And I can recall, you know, when I was a student, I remember one night with an aortic, 40 bottles lined up against the wall of the operating theatre that had been used in an aortic operation when they were taking out the whole thing and bleeding from the veins.
And then came the polyvinyl, and what it required was interoperatively to size the vessels. You had different mould, different bits of material, and you put it together, and then you put the polyvinyl, around this, put it in the autoclave. 10 minutes later you had a graft, a solid piece, and then you could take this apart and you had your graft, which you could sew in.
And we didn't have any laboratory, we didn't have any ethics committees, we didn't have anywhere to do any research. And I thought the only way, we've talked earlier about the Ivolon sponge, which my colleagues and my friends at the General were using. And I thought this wasn't any good, but we got a bit of shirt material, and we had no facilities at our own hospital. But I rang up the veterinary school and asked them if they'd allow us to operate on some dogs, and they said yes. And we did, and tried them out, they worked, and we started them off just like that.
In 1957, the first graft that I put in at North Shore Hospital was woven nylon, and when you cut it, the edges frayed, so wouldn't hold stitches. So you had to cauterise it to make a little rim which would hold the stitches. That was the first and last that I did. It wasn't pleasant.
Alan had his wife in the theatre corridors at Sydney Hospital, where they were using nylon shirts, which were very popular in the sort of late 50s. Came in the most fantastic psychedelic colours and were see-through. They looked terrible on people, but they were all right for aortic grafts, and they were tailoring them to a particular size, and Mrs. Sharp was sewing them up and he was putting them in. That also happened in Queensland. I think Sam Millick's wife used to sew a few grafts.
Yes, well, the manufacturing of the grafts was done because the authorities were not very keen on vascular surgery at all. Fortunately, Dr. Owen Powell at the PA was very supportive, but the authorities weren't and refused. They were not going to waste the government, the hospital money on grafts, so they refused to supply grafts. So we didn't have a lot of choice, and Sam used to give me the dimensions and one of the companies provided us with Teflon, and we made them at home out of Teflon on Terralid, on the old machine, and made them for some months. And eventually the authorities said, well, there were quite a lot of patients going through, quite a lot of people were needing grafts, so perhaps there was something in vascular surgery after all.
Dr. Mellick, I felt sure, wanted to be doing that first operation at this brand new hospital. We then wrote ourselves into the book then. We could all relax. And so later on I did a lot of his vascular work, and we enjoyed that. And character building, that vascular surgery and vascular anaesthetics, you often wonder, there must be some better way to earn a quid. But no, the one thing good about Sam was a competent, was a reasonably fast operator, didn't muck around. And he saw a problem, he dealt with the problem. He didn't, a lot of people tend to fuss and bother, what will I do? He knew what to do, and he did it in the most competent way. So I never had any problems in relation to Sam's approach to patients or surgery and patients at all.
Sam Mellick I consider to be a master craftsman. His operative performances were a work of art.
My first experience was in 1960. My chief then was Mr. William Eric Archer Hughes Jones, so he allowed me shortly back from Houston to put in a Dacron femoropopliteal above knee graft. And the delight on his face on the first post-operative day when he could feel a pulse made me be a vascular surgeon today. I think if he hadn't been able to feel that pulse, I wouldn't be here. Dr. DeBakey, who almost reached the age of 100, he is an extraordinarily industrious and highly intelligent man, first of all, and secondly, he is always seeking solutions to problems. And I think he has made possible what other people were simply dreaming about.
And I had been told by Charles Robb only 3 or 4 months earlier, when you go back to Melbourne, make sure that the first operation you do is an easy one and it'll go well. And here was someone with an isolated popliteal segment and a dead toe. She was about 80. Anyway, fortunately, everything went brilliantly. And the Professor of Medicine was most impressed, and I was off to a good start and went on from then. When Neil Johnson came here, we already had a good established vascular service, which I was doing, but I was very relieved for him to come because I was doing everything. And so he came, and that meant we were shared.
Dick Jepson was doing aneurysms at the Queen Eliz. Darcy Sutherland was doing them at the Royal Adelaide. Professor Jepson was a very kind person, but he was a person that somehow brought the best out of you. He was a person of extreme intellectual capacity.
I first was involved with vascular surgery probably as a student in about 1965 or 66 at Royal Perth Hospital, helping Gerhard Ebach do a ruptured abdominal aortic aneurysm. And he came to Perth in about 1965. A tremendous chap to work with, a good technician. Then I saw how it really could be done well by Gerhard Ebach and Bob Payton, and I thought, well, it could only get better.
Well, my recollection was that certain prominent people, in particular Doug Tracy and Scotty McLeish, spoke against the motion that we separate totally from general surgery.
I believe first and foremost we're all general surgeons. We learn our trade as vascular surgeons, and vascular surgeons specifically do things to arteries and so on, but we all have to make wounds, sew up wounds, repair other things.
Someone who wants to do nothing but vein surgery is a legitimate specialisation. And do they have to be trained to do Doppler, get a diploma in ultrasound? Do they have to be trained in endovascular catheterisation?
I think the movement towards that was irresistible by then. And despite what Doug says, there was a lot of animus in council.
So it's a changing field, and I don't regret specialisation in vascular surgery at all. But I don't think we should lose sight of the fact that there are many aspects of surgery to which we all have to attend, whether we're vascular, urological, neurosurgical, and so on.
I recall well from one of my peripheral training jobs here as a registrar, the general surgeon said he'd done 13 ruptured aneurysms, and he was none for 13, not one survivor. And it clearly became obvious that this was a separate specialty for people who knew what they were doing in that particular sphere of work.
Because it became very clear that people who were doing this particular amount of work repetitively and frequently, particularly if they were properly trained, got so much better results. It was an emerging specialty with a rapidly increasing workload, and so the general surgeons were busy in those days, and so the vascular surgery specialty unfolded.
The numbers of people doing vascular surgery was gradually increasing, so that at the end of the General Scientific Meeting in Hobart in 1972, those interested in vascular surgery discussed this topic, and at the end of the meeting, and with the help of Ray Chapman, who had helped me in drawing up a constitution, we moved, and I think it was passed without dissent, that the college form a section of vascular surgery. Well, the words keep changing, but the basic ideas, I think, remain constant. I see the college as the trunk of a tree with, I think now, approximately 11 large branches, all of which have their twigs. But if those branches become disconnected, I think the public will suffer.
Well, I was guided into vascular surgery after a general surgery training, which was the pattern of things in the 1970s. And I was fortunate enough to have as one of my mentors Scotty McLeish here, and his stories of Houston were hard to believe and very tempting, and he really, I think, catalysed me into vascular surgery. And so that set me up. There was very little I hadn't seen by the time I came back to Australia. And so when I started fortuitously at Royal Melbourne Hospital, the vascular surgery unit was formed in 1975, and I arrived back eager to go at that stage.
And it seemed very obvious to me that general surgery was a shrinking violet, and so I thought that vascular surgery was the way to go. So I got on the phone in a rather mischievous way and telephoned Jesse Thompson over in Texas and said, any chance of a job in Baylor? And to my surprise, I think he was rather astonished and taken aback. He said yes.
But an attitude and the horizons expanded in Houston immensely, so that there are a number of times that I saw things that I didn't believe could be done. We were going to the operating room one morning, and there was a very debilitated patient with bilaterally severely ischemic feet, no femoral pulses, and he looked quite socially disadvantaged, you might say, an under-the-bridge character. And I asked the boss, why are you bothering with this person? He's obviously not going to do well. And George Morris looked at me and he says, Wiley, come to the OR today, you're going to learn something.
By 1978, which was 2 years after I came back, they established what they called a vascular clinic, and that was attached to John Connell's unit. And the next year, 1979, it became a fully fledged vascular surgical unit.
When I arrived in the unit as a registrar in 76, which is just after the unit had been formed, it could have been 75, I was impressed immediately by the way that the unit epitomised the word unit. It was a group of 4 people, Ian Ferguson, Ken Stutchbury, Sam Rosengarten and Alf Barnett, who actually worked together as a unit.
In Western Australia in 74, vascular had already been formally separated from general surgery by Bob Payton.
I think Bob Payton was the driving force. He saw that if vascular surgery was to be carried out appropriately, then it had to have its own unit and its own ward.
Well, Jeff Allen and I in Hamilton were determined to provide a proper service. So there were just two of us. So we provided a 1 and 2 roster on call. Our families missed out on a lot of our attentions, I guess, you know, school functions that I wasn't able to attend. But we felt that that's what we had to do if we were going to provide any sort of a vascular service.
The Mai Tai Vascular Group was a group of 11 vascular surgeons who met up in Hawaii. The only one I knew before was Justin Miller, and they came from every state. Gerhard Ebach from Western Australia organised it. It was a 5-week trip to the USA, visiting about 6 units and taking in 2 or 3 conferences. And I'd only just opened the unit at Flinders 2 years before, so it was a great eye-opener for me. I learned as much from my Australian colleagues as I did from the Americans we visited. 2 Mai Tais on jet lag was a great cure for the trip from Sydney to Honolulu. Some famous people who were there were Justin Miller, of course, I mentioned. There was from New South Wales, we had Greg Leslie and Stuart Hazelton, Phil Robinson from Newcastle, Barry King from Melbourne, and we got to know each other pretty well over those 5 weeks.
I think vascular surgeons today would have progressed to their present state in spite of the Mai Tai Society.
The stories about Justin of tearing between hospitals in his operating theatre gear because he'd gone to a private hospital to do an open aneurysm repair, and he'd got there and he'd set up the patient, he'd operated on the patient, and when he'd gone to do the operation, he'd suddenly remembered that he'd forgot the graft, and he'd walked out into his Nissan 230Z, hopped in it with all his operating gear on, his hat, his boots and everything, and he'd been pulled over by the cops because he was speeding between hospitals.
I remember those wonderful diagrams he used to draw by hand with all his complications and show them at international meetings, but he was very much the conscience of the international vascular scene. Everybody knew him at all those international meetings like the International Society of Cardiovascular Surgery, and he was a legend in his own time.
But Justin always gave the last paper, and here he was with about 100 slides preparing his paper while I had my 10 slides being put into a little cartridge, and I thought, this man really was brave.
As has been said, you know, I think that Justin was our alter ego. At conferences, he would present the most horrendous cases, and he would really just sort of bring it to the surface the sort of fears that all surgeons have, that when they put a clamp on, the aorta might just fall apart.
But he was totally devoted, I think, to vascular surgery, and he was a bit of an absent-minded professor. I remember him telling me that he mistakenly went home in someone else's shoes, having changed at a different hospital from where he started. And Jan said to him, "Where did you get those shoes from?" And he said, "Oh no, but they don't fit me all that well." And it was really that he was a bit vague about things like that. But he said to me once that people thought he was vague, but anyone who could find an aircraft carrier in the middle of the Pacific flying a Spitfire had to have something, you know, going for them, and I think that was true. He was prepared to share his failures, and he did it because he wanted people to know and to learn and not to make that mistake. And I think it's a mark of a mature person that they can get up and actually say, "Look, I did this and I got it wrong," you know, and learn from it. And that was one of his great assets.
I count myself lucky as having been able to travel. In 1960 I first went away to America and to Britain. I'd read the literature and I thought I should go and see a select number of people. Jack Wiley in San Francisco, DeBakey in Texas, Linton in Boston, and I went to Britain and I thought I'd see Rob and Eastcott, and it was important to let them know that at the other end of the world there were people doing the same work as them. The ISCVS was quite a strong organisation with the International Society of Surgery, the SIC, in the 1950s and 1960s.
I was initially introduced to this body when I went to a meeting of the European chapter of the International Society in Amsterdam in 1966. And my research work at St Bartholomew's Hospital in London was presented by my boss, Professor Jerry Taylor, who at the start of his talk said that what he was going to talk about was the work of a young Australian surgeon, John Royal. And in the audience was Alan Sharp, who was a vascular surgeon from Sydney. He enrolled me as a member at large of the International Cardiovascular Society.
In the end of the 1960s, Alan Sharp in Sydney, who was a general surgeon with a vascular interest, particularly in sympathectomies, tried to get people to join the International Society. He must have been an early member.
I actually, with Sam Malik, joined the executive committee meeting of the ICVS. We were told that if we were going to go forward, we would need to have a number of members at large in order to form a chapter. In actual fact, the requirement was you had to have 50.
And Justin kept phoning me up to say, hey, will you rouse up a few Victorians to join the ISCVS? So I sort of became his Victorian recruiting agent in the beginning. We all went to the meeting in Athens. I think a lot of us did, which was the precursor of the setting up of the chapter, which happened in Rio 2 years later. And we finally had a chapter established, and with Justin as the president and Bob Lusby as the secretary.
Because I think they thought I had little else to do, just having started in a new job, I was elected secretary-treasurer. But of course that's really a key role in any society, because often you get to do the work and set some of the agenda at least. I was lucky enough in that direction. And what I really set out to do was to have meetings that weren't in individual hospitals. And the Regent Hotel in Sydney was up and running. It was sort of the hotel in Sydney of the day. And so I started having annual meetings there, which meant that people came from all the hospitals and from interstate to that meeting. And we did that, well, that was really the start of it, and it's still going.
In 2001, we changed the name from the chapter to the ANZ-SVS, and it was in that year that we adopted a new constitution which enabled the amalgamation of the ANZ-SVS and the Division of Vascular Surgery.
Well, it's interesting for those of us that are members of the vascular group in America to go to some of their luncheon meetings not so long ago, and they were acrimonious. They were infighting, and you had a group that wanted vascular to be part of general, and you had those wanting to have vascular emerge as a separate specialty. And I think we were blessed in this country by avoiding the worst excesses of that divide.
Charlie Hahn, who was the doyen of European cardiothoracic surgeons in Switzerland, and he said to the small group, the committee, it's time we had someone from Australia, and he looked at me and said, could you be the president? Well, I had hysterics. I didn't no idea about this. And I said, well, I certainly could. And he said, well, we'll look into this. And they announced it at the meeting in Amsterdam.
The situation had changed completely, though, by the mid-90s. There was an increasing divide between cardiac and vascular. It was apparent that something had to be done to the society, because we'd had decreasing numbers at the international meetings, which were always very well attended back in the 1970s and the 1980s, and there was a gradual diminution. So the solution that I came up with was that we should split into two separate societies, still with the same administration, but a cardiac component and a vascular component, which is what in fact happened at our subsequent meeting in 2004.
Alf Barnett was in charge of the ward. Alf Barnett had a particular interest in vascular surgery, and I used to have to assist him with his plethysmography, which was a displacement type of plethysmography.
And this is a skin thermometer which works by placing the little button there in contact with the area of skin that you're trying to record the temperature from, and that thermometer still works today.
It all started in about 1961 when my boss, Mr. Neil Johnson, suggested that it would be a good idea to measure blood flow, and the reader in medicine at the Royal Melbourne, Austin Doyle, had a strain gauge plethysmograph. It was a dreadful machine, very difficult to use, and but he loaned that to me, and we started measuring blood flows in limbs, not with any particular goal in mind, just to see what it was all about. And shortly after I started doing this, Professor Bill Irvine, who was the Professor of Surgery at St Mary's Hospital in London, came as the guest professor for the summer period, and he was very interested in this and asked for a demonstration. I demonstrated, and the machine promptly broke down so that I couldn't get it to work, but he took me on faith and said, all right, well, if you can get a scholarship, come and work with me and we'll set up a system to let you do some experiments.
And in 1978 I went to the United States and spent quite some considerable time with Wesley Moore, and I purchased an oculoplethysmograph, which is a machine that you attach to each eye, and it measured the arrival of the carotid pulse wave in the eye.
In 1969-1970, Jimmy Yao, when ultrasound was not a clinical modality, he had done a PhD using directional Doppler, and he had a laboratory there. Now, John Bergen had been in London, had seen this, and headhunted Jimmy Yao to Northwestern, I think it was, in Chicago. And so Jim went to Chicago, and I took Jim's job, and I learnt this Doppler thing. And I must say, at the time, I thought, well, this is funny technology. Show me a really good, clear angiogram, which shows me exactly where the blockages are, and that's going to be a lot better. I hadn't fully appreciated the physiological application of ultrasound in being able to determine what you were doing.
I think the 80s saw establishing better criteria for intervention. And so, having worked in Bristol with duplex scanning, I was actually recruited by Bill Ehrenfeld and Ron Stoney to go to San Francisco and set up a vascular laboratory there, which I did, and we then got involved with the Hoffrel company, and Hoffrel was one of the first pioneers of ultrasound for clinical purpose.
And so when I came back to Sydney in December 1971, I felt a little bit naked without ultrasound, because we had reduced our aortogram rate to probably 50%. Because if Dopplers were normal at the groin, we didn't worry about doing aortograms, which in those days were frequently translumbar and frequently complicated by pancreatitis or bleeding. And as far as I'm aware, the next dedicated vascular laboratory in Australia was in Brisbane, where Bill Campbell established one in 1975.
The progression of the labs since the 80s is that they've become much more specialised as opposed to a generalised department of clinical measurements. They've the ultrasound, of course, is much higher fidelity and you know, third, fourth generation equipment compared with the equipment back then. And also the plethysmography, which was the mainstay of a lot of departments, PPG, air plethysmography, strain gauge, was used in conjunction with duplex, early duplex scanning. I think you'll find most of that stuff other than CW Doppler and maybe PPG for digit analysis is gone.
In St Mary's in London, the B-mode and the directional Doppler were combined, and of course this was the beginnings of a so-called duplex scan.
Well, when I started off with the vascular laboratory at Prince Alfred, it was at the invitation of Jim May when I came back to start it off. And it soon became apparent that we had to train our own technologists to do that. And at that time we were under considerable criticism from radiology, and I was very keen to make sure that we all had appropriate qualifications for the people doing the work. But clearly we needed our own programs, and I was on the council of the Australian Society for Ultrasound in Medicine, and we then developed the DDU in vascular and the DMU in vascular, which to my knowledge is the first integrated physician and technologist qualification in vascular non-invasive technology.
Charles Dotter visited us. I visited Grunzig. It was very interesting to see how these techniques were first shunned by the vascular surgical community, and they took quite some time to think that there could be any substitute for a fempop bypass.
In the, I guess, what, 66, 67, Bill had read about the Dotter procedure, and so Neil said he'd provide some patients, and I was sent off to make sure that everything was done properly. Bill did a number of Dotter procedures very successfully.
Well, it really started with occlusive disease, and for me it started with atherectomy. And I had been in the United States, and I was at a meeting at the Bay Area Vascular Society one evening, and this guy came along who was a cardiologist, which was unheard of. And in those, amongst those people were Ron Stoney, Aaron Felt, who were really bitterly against any form of intervention, and still are. And as a consequence, when this fellow was invited, you could feel the atmosphere, you know, it was really unhappy. And I thought it was a bit of a novelty, and I wasn't paying much attention until he started talking about angioplasty, and that just blew my my brain away to some extent, and I said, I've got to find out how this happens.
Then we went over and observed and learned from John Anderson in Adelaide. And that was a remarkable experience at Ashford when we went over there, but he had consummate skills. And then we brought these pictures of these techniques back and discussed them at our various surgical forums, and it really ignited an interest in all of the surgical people there, even those outside vascular surgery could see that there was something going on here.
We learnt the skills of open surgery, and they were still being developed. And I can remember when I thought I'd almost made it, and then this chap called Michael Lawrence Brown came along, and he said, well, now we're going to go through catheters.
My interest in endovascular surgery started in occlusive disease in 1975, probably, when Dotter visited Royal Perth Hospital when I was a registrar. And I went to his lecture, and he showed the dilatation by the Dotter technique, and then later When the balloon angioplasty came out, that was it for me, and I decided that that had to be part of my armamentarium.
Fogarty Chin, and they were an extrusion balloon. And the balloon was actually packed into the delivery system, which was probably about anywhere between 7 to 9 French in those days, just for the system. And it had the balloon in it, and you bumped up on the obstruction, you held it there, and you fired it off, and it unrolled itself and went boom. But I used to use those in the operating theatre, and sometimes with some imaging, and mostly not. But all I kept doing was firing the thing off until I got a big flow coming down it.
A number of devices were coming out at the time, and one of them was an atherectomy device, known as a TEC device. And the medical company representative suggested I come to Adelaide to meet John because he was using this device and I would get an introduction to it. So that was my introduction to John.
And our relationship survived, whereas the atherectomy device did not. But still, it got us started. Michael's much more cerebral than I am. I like to work with my hands, and he has some really fascinating ideas. And in some cases, when he came across these, he'd get them built and come to me and ask me to do them. That's true, isn't it?
That's true.
Say that the first paper presented by Parodi, I think in San Francisco, it was a breakfast session. He had 6 cases. And that meeting usually has about 2,000 odd people, and the breakfast sessions are popular. 20 people turned up. Jim May and myself were among them, because it just seemed outrageous that anyone could fix an aneurysm using this technique.
At the convention there in 1991, and at that time I thought it was an idea that wouldn't work out in practice. But after thinking about it for a year, when I heard him speak again in 1992, I felt that it definitely was worth looking into further. We were able to proceed on to do our first case in May in 1992.
So when Parodi was going to go to Royal Prince Alfred Hospital and the flyer for the hospital meeting came out, I saw that. I just jumped at it. Things tend to happen because the ingredients are there. I guess it's a bit like cooking. So Perth is very isolated. To fix anything in Perth, you have to have the expertise. You can't send them on anywhere else. When I went to Royal Prince Alfred Hospital and saw that they could actually treat aneurysms with an endograft, the ingredients for me were already in Royal Perth. I already had the skills in interventional radiology from the work in the 80s. We already had the technical skills in terms of putting devices together because that had been developed.
Well, I wasn't really keen on it at all, if you want me to be honest. And I had great hesitance to step into it because I've been all that time an open surgeon and had done many aneurysmal repairs. And so we trooped off to Perth and we got there, and you wouldn't believe it, they had these stent grafts which were not packed in anything. And they had sharp little springs on them and sharp little hooks, and they made you load them yourself into the delivery system. And all I remember is all these pricks all over my fingers that hurt like hell, and I wasn't really taken by the graft at that time. Michael has really been a leader in the treatment of aneurysmal disease in Australia. The device that Michael had been involved in has continued to expand and is still doing so some, 20 years nearly since we started?
15.
15?
My association with John was that if we needed a test pilot, then he would be a good test pilot.
And they told me of the guy Claude Miali in France who was putting in similar devices to exclude aneurysms. This fascinated me, and so I arranged to meet with Claude Miali at a meeting in Marseille. It would have been in late 1993, He was very unenthusiastic about coming to Australia and doing cases. He had far too much work to do in Europe and was far too far away. But we struck a deal that if I could stick with him for the next 2 weeks while he did several cases all over Europe and be there at the end, then he'd come to Australia and do the cases. He almost lost me many times, but we managed to catch him on every occasion, and he finally admitted defeat and came out. And we arranged 5 cases. They were performed on the 4th and 5th of December 1994. So it must have been 94 that I was in Europe earlier. I can remember their names, it's so clear in my mind. They all did well. Terry Devine and myself did a large number of those in those early years. They're very difficult to deploy and very difficult to put in, but nothing like the grafts of today, but they worked.
The endovascular revolution does bring some concerns. I mean, it mates you up as the surgeon and the clinician with an industry who've got products to push, more so than in the days of old open surgery. I suppose the other thing about the endovascular revolution is a bit of a philosophical one of keep raising the level at which you would do an intervention on a patient, that we perhaps run the risk of over-treating some people in the dying day, or in their final days, and the philosophy being it's not quite a big operation, and I think we have to be careful of that. Skepticism is often not borne out. I mean, it's this question of the right amount of skepticism, but a lot of things that intuitively I felt would never work have worked, and I suspect there'll be a progression of that.
With regard to the formation of a division of vascular surgery, in 1981 the College Council decided to set up a divisional format with separate divisions for orthopaedics, plastic surgery, neurosurgery, ENT and so on, 9 of them, but vascular surgery was not asked did they want to become a division at all. It was assumed that they would be part of the division of general surgery. And they actually were galvanised into action at the Sydney GSM, as it was called in those days, in 1991. John Harris was the convener of that meeting, and he wrote to Bob Payton at the time to say general surgery were allowing almost no time for vascular surgery in the meeting. And so basically at that meeting, it was moved by Bob Payton that we form a division of vascular surgery to be distinct from general surgery.
I think it was a combined philosophical decision. There was the impetus in the workplace. There was a lot of things happening, and there was no objection. And it just seemed, I think other specialists have gone on to divisions, and it seemed the natural thing for us to do. There are just some who felt that we were moving too far away from general surgery, and they still wanted to maintain their bonds to general surgery for all sorts of reasons. That would probably be the only opposition that was probably within our ranks.
The college initially, for the first few years, was quite apprehensive, and they worried that the general surgeons, whom they saw as a group who were forever being eroded, would be, suffer further. And really, I think we can say it was only when we put pressure on the college to run our own meetings that we actually started to make real headway. And later on, people like John Royal and so on, yes, they did facilitate then that development within the college.
And the result of the plebiscite showed that 80% of the vascular surgical section members, they worked exclusively as vascular surgeons, and so it was passed, and that was passed before I became president. Well, I thought that it was the greatest honour I've ever been given, and it's an incredible privilege to be elected to such a post, but also I felt quite strongly it carries a big responsibility to act in the best interest of surgeons throughout Australia and New Zealand.
It was just a gradual recognition that vascular surgery was a specialty in its own right, which prompted then the move to get a division of vascular surgery, which actually meant that it was then recognised as a specialty.
I think in terms of training of surgeons at that time, England was the primary training centre. There weren't many people trained by America at that time. I think that was a later evolution, the American training.
In that era where they were really trying to develop registrar training in Australia, and then also getting people into appropriate training programs overseas.
Dr. de Bakey was certainly a hard taskmaster. He required of his trainees exactly what he required of himself.
Jesse Thompson was a gentleman, astonishingly hard worker.
Jack Wiley was an extraordinarily charismatic character. He used to walk with a slight limp, and his charisma was such that Stoney and Ehrenfeld, both of whom absolutely worshipped him, they used to unconsciously or whatever also walk with a similar limp.
A generation ago or so, we would all go overseas to get our training. We are now really self-trainers, and in fact, because I think of our flexibility and willingness to adapt to new ideas such as endovascular, we're getting a lot of people from overseas coming here now to learn those techniques. It's still an apprenticeship, and I think people still seek out those who are doing certain procedures well to learn that skill. There's no substitute for actually being an apprentice of one form or other.
Nevertheless, there were not any guidelines as to volumes of work and exactly what trainees and registrars and so on had to do.
I was not formally trained in vascular surgery. I acquired vascular surgery during my general surgery, and that is in conjunction with opportunities and an interest meant that I was appointed eventually by election as a consultant vascular surgeon in '84.
Before we formed the division in 1995, there was no formal examination at the end of the training program for those that came into the sectional training, which was 2 years, but it wasn't assessed at the end of that. And when we formed a division, we then had to set up a final exit examination.
John, of course, contributed on many fronts to vascular surgery. He was the first chairman of the Training and Accreditation Committee when the section of general surgery was formed, and so was very integral in the training of the new generation of vascular surgeons.
And in 1983, when the college section, as it was, of vascular surgery had been 10 years old, it formalised the training into a 2-year certificate training in vascular surgery. And it was only in 1995 when the division was formed, the characteristic of the division being that it has a training program and an exit examination and a full fellowship diploma with a board of surgery attached to it and a board of examiners. The fact that we've trained so many surgeons who've gone on and made successful careers in vascular surgery really wraps it up for me.
And once we had control of curriculum, then we could do what we'd like with vascular surgery and take it in the direction we wanted to, and the direction that John Quinn and the board wanted to go was to incorporate endovascular training into the curriculum. I joined the board and took on that task with enthusiasm.
The Conjoint Committee for Accreditation in Training in Endovascular Therapy started on the model of what had been done for endoscopy, where surgeons had been actively involved in endoscopy but needed some recognition for their training. And an intercollegiate committee was set up at that time, which I think has served the purpose well.
What's enormously important is what has actually happened to vascular surgery in this country. That is, it's been recognised as a specialty We got that early on in 1995. We developed our program, and I think that's been a great tribute to all the people that have worked to set vascular surgery up where it is today, and I believe that we have the best training scheme in the world.
Because vascular surgery, we all know, is very demanding, and even something like aneurysms or carotids, if your results were bad, it was obvious to you, it was obvious to everyone. And to get over the line in that area of surgery, and now you're acceptable, reasonably competent, I think we all breathe a sigh of relief when we realise we could do 100 carotids or 100 aneurysms with reasonable figures.
Sam was an irrepressible bundle of energy, I think you'd have to say. But was very enthusiastic about research, was very enthusiastic about audit.
I'd like to keep sight of our obligations to the community in making sure that our results are up to world standard, if not ahead of the average.
So I think the biggest achievement has been the changes in our Articles of Association mandating a requirement to audit our work.
And also being able to monitor outcomes in a way that meets the requirements of every individual surgeon, but also external bodies in that. And I think that's going to be another challenge that we will have to face.
Retirement is not, as they say, a rest.
That's a bit of peripheral arterial surgery.
The question is who among the Australians have taken vascular surgery forward. I actually think there's a whole lot of people who have done that, and from every state.
Darcy recalled how John had successfully treated his suprarenal aortic aneurysm with a fenestrated endograft a year or two earlier. On the 50th anniversary of Darcy performing the first open abdominal aortic aneurysm repair in Australia, one cannot envisage what changes the next 50 years will bring.
I'd just like to say that you've been extraordinarily lucky to be involved in an area of surgery which has evolved while we've been in it.
I'm of a generation that has really benefited from the previous generation of what Ian Ferguson and Ken are part of, where they're actually working out the operations of vascular surgery. And in fact, what they were demonstrating to us as trainees was a sense of adaptability, a sense of an inquiring mind. And in fact, I think it's those attributes that have enabled us to embrace endovascular surgery so easily. And again, I think we owe them a debt of gratitude.
I'm sure that we'll be doing more and more minimally invasive work.
We don't have limitations. We can do open surgery, we can do endovascular surgery.
And vascular surgery, as I knew it, was no longer.
I've enjoyed my life as a vascular surgeon. I've enjoyed the transition from general surgery to vascular surgery.
I think we've punched above our weight as a specialty, and I think there's enough of us now to justify being independent, and I think we should recognise our shortcomings. I think if you don't find your flaws, they'll stay.
I'm amazed at the changes in the sense of the development of endoluminal arterial surgery. I wouldn't have believed it in my day, and I'm not sure that I believe it now.
I have no regrets because I think it will continue to progress. There are many more things to be done, and we will have to do that hand in hand with developing technology.